Between July 2012 and December 2017, 17% of the patients filled a postoperative prescription for opioids. The group included 16% of those who received a peripheral nerve block and 18% of those who did not. Although this small difference was statistically significant on initial analysis, it didn't hold up as being clinically significant in several subsequent sensitivity and subgroup analyses. The study was not designed to assess whether the nerve block worked or what other medications were given during surgery. Most importantly, the authors could really not show whether the opioids were consumed once the prescriptions were filled. However, the results do show that a peripheral nerve block was not effective in reducing postoperative opioid fills after outpatient shoulder surgery. You can read this article for free in this month's issue. Next, let's look at a retrospective cohort study of hypoxemia risk in young children who are undergoing one-lung ventilation. Assessment of best practices is really challenging in this patient group because the procedure is rare and highly specialized. Although current approaches usually involve endobronchial intubation or bronchial blockers, few data exist to support either strategy. To better characterize these approaches, Dr. T. Wesley Templeton of Wake Forest School of Medicine and colleagues examined 306 pediatric cases from 15 institutions. The study population was 2 months to 3 years old, and they underwent non-cardiovascular thoracic surgery with one-lung ventilation. The primary outcome was at least one episode of hypoxemia, and this occurred in 81 of the 306 patients, including 56 cases of severe hypoxemia. Overall, the use of a bronchial blocker was associated with a lower risk of hypoxemia and severe hypoxemia in both univariate and multivariate analyses. The exact reasons for this difference really remain unclear, but the authors suggested that endobronchial intubation, while technically easier to perform, may yield a less effective seal and allow for more leakage of serosanguinous debris from a surgical side into the dependent lung. The authors also noted that hypoxemia risk was significantly less in left-sided surgeries, apparently independent of the approach used. Another clinical observation: cases using a bronchial blocker had a lower median fraction of inspired oxygen compared to cases using endobronchial intubation, which aligns with the lower hypoxemia rate in the bronchial blocker group. This article is available for free in this month's issue. Our last study looks at surgical scheduling and caseloads. It was a report of a time trend analysis, which explored the relationship between anesthesia case volume and time of the year. Previous studies have shown no particular association between month of the year and anesthesia case volume. However, the increased use of high deductible insurance plans in the United States suggests that more people might schedule elective surgeries later in the year when they're more likely to have already met their deductible. In a 3-year retrospective study of more than 3 million cases in Texas and Florida, a team led by Dr. Anastasia Piersa of the University of Chicago found a 20% increase of cases in December compared to a January to November baseline. On further analysis, the association was observed for colonoscopies, which are usually elective, but not for coronary artery bypass grafting, which is rarely elective. In addition, the authors found that greater proportions of December patients were both commercially insured and younger compared to surgical patients in January to November. Overall, the authors concluded that the findings may provide insights for policymakers on optimizing health insurance delivery based on how patients decide to schedule elective surgery. In a related editorial, Dr. Warren Sandberg noted that the study findings may seem obvious on first glance, but they do provide a conclusive picture of the December rush that may be so ingrained in clinical practice that it goes unnoticed. Dr. Sandberg emphasized that the study findings highlight the need to plan staffing accordingly in order to accommodate the higher volume. He added that patients' insurance issues may be worth considering when deciding whether to defer surgery. This article is available for free in this month's issue. Our clinical focus review this month tackled the topic of dexamethasone, the risks and the benefits in non-cardiac surgery in adult patients. Doctors Paul Miles and Thomas Corcoran of the Alfred Hospital and Monash University in Melbourne, Australia, and the Royal Perth Hospital in Perth, Australia, conducted a literature review to update the evidence supporting perioperative dexamethasone for a range of uses. The article begins by reiterating the safety and effectiveness of dexamethasone for postoperative nausea and vomiting, either alone or in combination with other antiemetic drugs. The authors next cited data to show the safety and effectiveness of dexamethasone for analgesia in certain surgeries, including spinal surgery, ear, nose, and throat surgery, tonsillectomy, and joint arthroplasty. The latest data also show that dexamethasone has been shown to reduce opioid consumption and that dexamethasone-treated patients needed less rescue analgesia for intolerable pain. Data were also said to support a positive effect of dexamethasone on the quality of recovery based on a global Quality of Recovery 40 scores at 24 hours after surgery. And importantly, while dexamethasone can cause a small to moderate increase in postoperative glucose concentrations, the patients with diabetes were not at increased risk of surgical site infection if they received dexamethasone. Multiple studies continue to support a dose of 4 milligrams as effective for postoperative nausea and vomiting. However, the optimal dose for analgesia benefits remain unclear. The authors concluded that most recent studies suggest that 8 to 10 milligrams may be needed to improve the quality of recovery. And our last article this month is a review on the evolution of the American Society of Anesthesiologists Physical Status Classification System, which celebrates its 80th anniversary this year. The review was written by Drs. Balash Horvath of the University of Minnesota in Minneapolis and colleagues. The ASA Physical Status Classification has long been controversial, in part because it was designed as a tool to collect data on a patient's status before anesthesia, but was not designed to predict postoperative risk. The original description appeared in the May 1941 issue of Anesthesiology. It was the work mainly of an ASA committee, Drs. Meyer Sacklid, Yvonne Taylor, and Emery Rovenstein. They developed 6 designations, classes 1 to 4, to describe a patient's physical status before surgery, and classes 5 and 6 to apply to patients prior to emergency surgery. The review recounts the history of the ASA physical status and highlights some of the research showing that it can contribute to assessment of risk and outcome if used with aggregate data. However, it has dubious value for predicting outcomes in individual patients, although it has been used for this purpose. For the most part, the ASA physical status has remained unchanged for over 80 years. One key modification was the 2014 edition of examples of patients for each physical status category. And this was followed in 2019 with an update that allowed anesthesia departments to develop their own institutional examples to supplement those approved by the ASA. And the most recent update in December 2020 added examples of pediatric and obstetric patients to each category. As far as future modifications, the authors said they believed most ASA members use the ASA physical status as intended, which is to summarize and compare preoperative health status of surgical patients. They envisioned continued use of the ASA physical status as a bedside tool for anesthesia providers and others. Whether any more modifications are needed will depend on the future needs of clinicians and researchers and regulators. However, the ASA and its members have the final input on how to keep this enduring tool current and able to meet diverse demands. For those of you who attended Anesthesiology 2021 in San Diego, either in person or virtually, I hope you made the most of the opportunity to reconnect and explore the latest topics in the field and learn the latest information. You can always find new studies and commentary on the journal website, anesthesiology.org. And as always, I thank you for listening to the podcast and thank you for your support of the journal. I hope you'll find the information presented to help you guide and improve your clinical practice. I look forward to sharing more important information with you next month.
Discover the difference with Masimo SET pulse oximetry. Since its introduction in 1995, Masimo SET has been shown in over 100 independent and objective studies to outperform other pulse oximetry technologies. Visit Masimo.com/SET to learn why SET is trusted by healthcare providers all over the world.